Great. Thank you for having me. This has been a really exciting day. I've learned a lot already. So we can jump right in. Dr. McDonald did a great intro for some of my talks, so I'm not going to have to go over everything. So as we've heard many times today, heterotaxy results in abnormal arrangement across the left-right axis, and there are 3 possible spleen outcomes. You can have a normal appearing spleen, you can have polysplenia, and you can have asplenia, and all are at risk of abnormal splenic function and heterotaxy. And as we've discussed, they're at specific risk for encapsulated organism bacteremia or invasive infection. And so as we talked about, and I'll just go over this data pretty quickly because we've reviewed it already, there's about an average of a 5% lifetime risk of bacteremia, and most of our data is coming from the sickle cell population and post-traumatic splenectomy. But what we know about bacteremia is that it's specifically dangerous, and our patients are at risk of this overwhelming infection that happens so quickly. And so we really try to guide our patients as much as possible about the risks, what to expect, and how to act appropriately. But we base a lot of our data on these bigger patient populations, but what do we know in heterotaxy specifically? And just a couple of points to point out here. This was a review that was done back in 2016. And I think the things that jumped out to me here were that, the age that we know right now is that 17 months is the average age, but these were pediatric studies. And so in heterotaxy specifically, we just have a big lack of adult data. And so there's, a lot to work on there. The other thing that really jumped out to me is that, I do think sometimes people see normal spleens or polysplenia and think that maybe that there is some splenic function. And what we know about our patients with heterotaxy is that you just can't rely on that. Just because you have multiple spleens present doesn't mean that those spleens are functioning. So we really have to do the workup that Dr. McDonald suggested and make sure that they have splenic function and follow that along to make sure that these patients are safe from these bacteria. We won't go over infections because Dr. McDonald reviewed that specifically, but this is something that we go over with every patient so they are fully aware of the risks. The one thing I did want to mention was this paper. This is a very old paper now, but I still think it holds true. It's from Boston Children's here between 1950 and 1975, and they looked at infections in our heterotaxy patients. And one thing that I found was really interesting is that in patients above 6 months, it really matches what we talked about previously, that pneumococcus and Hib are really your primary organisms. But in our young babies, the ones less than 4 months, you are seeing E. coli, you're seeing Klebsiella in these neonatal sepsis-like pictures. So those are still organisms that we really have to worry about in our youngest babies. So how do we protect our patients with heterotaxy and abnormal splenic anatomy? So what I talk about with my patients and in our clinic is that there's really 3 pillars of approach, and all are very important. And so those are hypervaccination, antibiotic prophylaxis, and having a really solid fever plan that both patients and providers that they at their local hospitals, especially for rural Wisconsin, are aware of and comfortable with. So we are certainly not going to review in detail every vaccination plan, but I am going to hit the high points. So like Dr. McDonald mentioned, we're overwhelmingly worried about pneumococcus. This is causing most of the issues in our patients. And we are really lucky to live in a time where we have great pneumococcus vaccines. So this needs to be a conversation that we have with our families, that vaccination for pneumococcus and staying on top of current literature is super, super important. So the current recommendations are to receive our standard series, so infant series plus 18 months. And then what happens after that in the age of new pneumococcal vaccines is still, there are no guidelines for. So currently, before PCV20 came out, it was 2 PPSV23, so that's the polysaccharide version of that vaccine. Now that PCV20 is widely available, we are talking a lot about our patients about PCV20. I think it's a great vaccine. There's also really good data that these Prevnar vaccines or PCV20 decrease pneumococcus carriage in the airway. So I think this becomes a really powerful tool that we can use in our patients. Now, I do talk in this table about waning immunity and following antibody levels. Actually, if you look at the British guidelines from 2024, they say don't follow levels, but that is in the age of PPSV23 where we were doing where we were recommending PPSV23 every 5 years, no matter what. Now in the age of these Prevnar vaccines, I think that we really have to follow levels and see what our patient's immunity is doing and act appropriately, knowing that this is the biggest risk for our patients. Hib is really a vaccine success story. We see much less Hib now due to our vaccines, but we still recommend an additional vaccine for that for our vaccinated kiddos. Meningococcus, as we've already mentioned, is a big risk. So the normal pediatric vaccine series has that in later childhood. And for our kiddos, we are recommending that in the neonatal age range and then repeated throughout life. So there's only one vaccine that is well tolerated or has great safety data for that. So we typically recommend the Menveo vaccine series just the same time that you do the other infant series. Influenza we talk about a lot. We don't think that there's variation in influenza immunity specifically in our heterotaxy populations, but influenza carries a big risk of secondary infection due to mucosal changes, so we talk a lot about it, influenza for the whole family in the household. I did want to mention this now. Dr. McDonald talked about this a little bit too, and we just don't know. This was a small patient population, and we wish we had better studies, but this is looking at antibody levels to certain pneumococcus serotypes after vaccination according to splenic function at the top and according to heterotaxy versus CC, or cyanotic congenital heart disease on the bottom. And at least this paper showed that our patients can mount immunity to this. There was a lot of questions early on because of those IgM positive, CD27 positive B cells being absent, if they could make strong responses to these vaccines, but all the data we have so far is that they can, and they should be getting those vaccines because it's one of the best ways to protect them. So that second pillar on the image I had was antibiotic prophylaxis. We kind of touched on this earlier, that there's some controversies around it, but there's really no controversies less than 5 years old. And so the recommendation really is beta-lactams, penicillin or amoxicillin, and then there's alternatives listed for our beta-lactam allergic patients. This is what most of our recommendations are based on. This is one of the prop studies in the late 80s for sickle cell anemia, showing that you have a really large decrease in infections, cumulative infections on patients on penicillin prophylaxis. So again, in our clinic, this is a shared decision-making, as so many things that we do are. But the definite recommendations for antibiotic prophylaxis are birth to 5 years old. That is really solid data. And anybody with history of invasive infections, we are advocating for lifelong prophylaxis. And as Dr. McDonald sort of alluded to too, in any of our patients that have other immunocompromising conditions, it's just too many risk factors. And we also recommend lifelong prophylaxis. Beyond those conditions, data is really lacking on extension. And what I would like to see over the next 10 years is really gathering more data so that we can appropriately have these conversations with our patients and risk versus benefits. Because we know that patients, post-splenectomy patients, adult patients are still getting sepsis. They're still at these really high risks of high morbidity and mortality. But we just don't know the other side of things like adherence and effect on quality of life. And we don't know about resistance patterns that might impact how they do when they actually do get if they actually do get sepsis. The other thing that I often worry about, and I'm not sure that this is a real worry, but I do worry about it, is that our adults on antibiotic prophylaxis, that they'll have some sort of false sense of protection and not follow their fever plan. So again, this is a really open area of research that we really have to dig further into so we know how to protect our patients. So how do we protect our patients on the patients that we decide don't need, or through shared decision-making decide that we're not going to do prophylactic antibiotics? That really gets to the third prong of the the 3 pillars of plans. So the one thing that we really talk, there's a long first visit in my clinic, is we talk a lot about fever plans. There's a lot of patient education about what we've talked about before, what are the risks and what does the data look like. We provide a emergency room letters to our patients, and we usually advocate that they print those out and keep them in their wallet or in the baby bag or whatever it is, so that they can present that to the emergency room providers. I have found that to be really critical. I take care of a lot of patients that go to rural Wisconsin emergency rooms, and that has proved to be absolutely necessary to get the appropriate care. We also talk about standby antibiotics, because again, I have a lot of rural living patients that live over 30 minutes from a hospital, and these can be rapidly deadly situations. And so if they live over 30 minutes, that's my typical rule, is I will give them what we call standby antibiotics. Before we go to that, I did just want to review this fever plan that was nicely published in the New England Journal in 2014, and one that I still follow today. And basically, it might be hard to see on the screen, but basically if we have a fever in one of our asplenic or hyposplenism patients, we do recommend that they get to the emergency room as soon as they physically can. And it doesn't always mean, and this is really helpful for patients too with quality of life, as many children have colds and fevers, as it doesn't mean that you necessarily have to stay overnight in the hospital. You know, we do say if baby looks great and everything else is okay, that we can do a blood culture and a dose of ceftriaxone and send home for monitoring. Obviously, if the child doesn't look well, we do obviously advocate that the child is monitored overnight. The standby antibiotics for children and adults is typically Augmentin, but again, there are other options for beta-lactam allergic patients. One thing we talk, especially with my toddlers or babies with older symptoms, a conversation that we often have is, but she looks, there's colds around, like everybody's in school, it's okay. But one thing that we have to remember is that pneumococcus is our most common organism here, and the most common preceding symptoms of pneumococcal pneumonia are going to look somewhat cold-like. And so it's hard to be reassured completely, even if they're cold, similar symptoms. So important future considerations that I wanted to talk about before I wrapped up. So again, pneumococcal vaccine is such a powerful tool in our toolkit, but it's not perfect. We have to remember that even though our pneumococcal vaccines are covering up to 20 to 23 serotypes, there are other serotypes of pneumococcus, and children run into things that are not in the vaccine. Unfortunately, although this is not happening super quickly, there is evidence of strain replacement shown by the Lancet Infectious Disease paper on the bottom, meaning that as we protect for certain serotypes, the ones that we don't protect for are going to be more common. And so we have to stay up with the literature of new pneumococcal vaccines and following levels and seeing how we can best protect our patients. Again, we've talked a lot today about antibiotic prophylaxis, and that just needs to be shared decision with you and your patient, and staying up on current literature. And then I take a lot of my time in my clinic talking about fever plans and making sure that my patients really understand the risks of that, and I really feel like adherence to fever plans can be life-saving for our patients. And with that, I will close.